My name is Kayla McGriff. I will be covering what I talked about in my capstone presentation in regards to disease surveillance for sexually transmitted diseases. I worked on 2 projects for the Department of Health under the Harm Reduction Services branch, and I'm going to go into a little deeper in that. I did dive into introducing what disease surveillance and sexually transmitted diseases are. I thought it was important to make sure the audience understands what kind of goes into what the Harm Reduction Services branch does, including all of pretty much Department of Health and other public health organizations. But I wanted to dive deeper into what exactly disease surveillance is. It is there's a lot that goes into it. There's steps, tools, resources, public health professionals in order for it to be successful. And it's a big tool that we use to monitor health of a population. It is threefold, meaning it needs to describe a current burden of epidemiology or disease, monitor trends, and identify new diseases and outbreaks. It takes in disease surveillance includes epidemiology, which takes into account the frequency and pattern of any health events in populations. Pattern refers to the occurrence of health events in accordance with time, place, and person. So, for instance, time can be seasonal, yearly, or any other time breakdown that can influence disease development. Place includes geographical placement, whether it's rural or urban, or if anything was contracted or developed due to a workplace, public event, or any public institution such as malls, schools, concerts. And then some personal characteristics include demographics that can affect a person's health, such as age. Young people are more likely to catch certain diseases compared to older people, or sex. Socioeconomic status is very important to recognize, and any behaviors or environmental risk factors such as smoking or secondhand smoking. And all this you can get from the Centers for Disease Control Prevention website. And then disease surveillance can have different approaches to tracking and eliminating disease. There's a lot of different surveillances, more than I will be discussing in this presentation. But the ones that I wanted to talk about are active and passive surveillance, in addition to sentinel and syndromic surveillance. So I made a little chart here, kind of clearly stating the similarities and differences between passive, active, sentinel, and syndromic surveillance. Passive surveillance is for medical professionals in the community and at health facilities. They have to report cases to a public health agency to conduct management analysis once the data are received. So that one, it's not as immediate reporting as more so active surveillance would be. Active surveillance requires public health staff to engage actively. So they're constantly keeping track of something rather than just kind of gathering it as it comes. In active surveillance, it takes action in order to receive reports of disease cases. So it really depends on the disease, the aggressiveness of the disease, and how we, whether as a state, as a nation, as a community, are approaching the situation. So that's really, that can be up in the air of what kind of surveillance we want to use there. Sentinel surveillance involves selected health professionals to report cases on specific groups or geographic areas. This can obviously be active and passive. So one of the projects I work on today, it's a tool for sentinel surveillance. We're trying to pinpoint selected health professionals to report cases rather than just getting some random thing from an entire organization. And then syndromic surveillance, it's more focused on reporting specific symptoms rather than diagnosis of a disease. So what is disease surveillance? So we're going to continue on with that. It's just another part of the threefold thing. We just went over frequency. Now we want to go over the second part, which is monitoring that consists of routine observations, collection of information on disease to determine how it relates to the population. So just taking in a lot of data, making sure that we are observing what specific characteristics are coming along with the data that we collect. Some examples of monitoring trends in disease includes keeping track of vaccinations and treatments and how they impact the burden of disease, how efficient is a vaccination, such as using the coronavirus vaccine. How efficient is that? Is it keeping people in the community from getting infected? The last part of the chain of disease surveillance is to be able to tend to other outbreaks quickly and to prevent future ones, to either get to the disease to a point where it can be managed without uncontrollable spread or eventually eradicate the disease altogether. Some diseases, we really want to make sure we eradicate. And some diseases, we try to manage. Again, for example, COVID-19, most likely we're just going to continue to live with it, but we want to make sure we manage it so hospitals and clinics and any health centers are able to properly and safely treat patients. So I also want to go over what sexually transmitted diseases are. Just a quick little review. From the Centers for Disease Control and Prevention website, I just listed some basic information, such as what STDs are. They're the most easily contractable diseases in developed countries, such as the US, and also common disease developed during adolescence, young adulthood, marginalized communities, or just anybody. Really easy to get. A big reason why is because it's really hard sometimes to tell who has it, and a lot of the times you can't always get accurate information or data due to it having a stigma surrounding it. So STDs can pass from one person to another through oral, vaginal, and anal sex. Like I said, symptoms can range anywhere from asymptomatic or very minor symptoms that someone may not notice, or to major symptoms such as fevers, sores, infertility issues. So there's a wide range of what you can deal with when it comes to sexually transmitted diseases. They are very difficult to track, specifically in marginalized and stigmatized groups of the population, such as sex workers, the LGBTQA plus community, homeless populations, and others. The reason why is, it makes it difficult for these individuals to seek care and treatment due to fear of mistreatment and harassment. Obviously, very valid concern due to the history of violence against these groups in America and around the world. There's a lot of systemic issues when it comes to stuff like that. And the main goal of STD surveillance is to obtain information on the burden of STDs in the population, in addition to determining, describing demographic and geographic distribution of the disease. We want to know who's most likely to get it, where they're most likely to get it, what common symptoms and signs that they show, so we're able to kind of keep track and stay on top of it. So now I will be discussing disease surveillance through the Harm Reduction Services branch within the Department of Health. DOH is an agency branch within the federal government of the United States. The DOH's purpose and goal is to enhance and support health of Americans through a myriad of different avenues, but specifically in our case, infection control and disease surveillance. So the Harm Reduction Services branch is a branch within the DOH. It's a leader in organization efforts to address HIV, viral hepatitis, and other sexually transmitted diseases. Harm Reduction Services branch aims to provide support through education, partner services, and connections to its local network of care. So the project I was working on was definitely focused on improving the Department of Health's interaction and coalition with stakeholders in the community. So just like I was saying earlier, I did 2 projects that I discussed in this capstone. So I updated a provider point of contact list. This contact list was a little outdated. It has probably been updated in a few years. Some parts of it were updated more recently. But yes, I updated it for the Harm Reduction Services branch to assist disease investigators with disease surveillance, made sure all the information was correct, and added any additional information if needed. And then I created a guide to update the point of contact list, just kind of a smooth transition if anyone was training or if there was another intern who was given this list, that they are able to use that and kind of walk them through, so it saves everyone a lot of time and it keeps it organized. So before I go into the projects, I want to discuss the geography and demographics of Hawaii, because throughout my projects, you will see that there are a lot of different types of providers that we have to get in contact with. So I want to discuss that here. Hawaii is a huge melting pot, very diverse, and a lot of these communities are very unique to the state of Hawaii. So Native American, there's Native Hawaiians and Pacific Islanders make up anywhere from 12 to 16% of the population. The Asian population takes up anywhere from 35 to 55%. This is going off of the US Census Bureau of 2020. But obviously these statistics, they fluctuate. Out of the whole population, about 30% are white. It could range anywhere from 30 to 40%. And then for Black, that takes up about 2% of the population. I also wanted to include homeless population. It is very big in Hawaii, and it is important to note due to us having to have a lot of contact with homeless shelters. There was an entire list of homeless shelters that we wanted to have a specific point of contact with. So yeah, there's about 15,000 homeless individuals in the state of Hawaii. So it is important for us to recognize what a big population it is, and that we do serve them as well. In addition, there are 70,000 military personnel and their family members stationed or living in the state of Hawaii. And yeah, the state of Hawaii obviously is very unique, unlike any other state, where it's broken into 7 inhabited islands. Obviously there's more islands than that, but I'm more focusing on where there are people. It is very vital for the Harm Reduction Services branch to have accurate and thorough communication with not only local homeless shelters, in addition to military bases. Very important for homeless shelters because they are a marginalized community, and they are at higher risk for developing certain infectious diseases, including sexually transmitted diseases. So yeah, I mean, diversity among the population is very valuable, and it's one of the beautiful things about the state of Hawaii. So it's very important for federal and state organizations such as the Department of Health to understand the population geography that they are managing, so they can efficiently deliver disease surveillance. So for my methods, I included one of my projects that I worked on. This is the flow sheet I created for the guide on how to update the provider list. So I'm just going to go over it with this. So it takes a few steps, probably 4 or 5, relatively simple tasks, but still important to have a to-do list. When you first look at the point of contact list, what I did, probably the best way to do is go by subsection. So there's military affiliations you can pick from, hospitals, clinics, homeless shelters. So you can start with that. And after you select the subsection, You can go down the list. I went down the list of contacts already provided and checked if there's already a number or fax listed, and if there was a specific point of contact, like a specific person that I need to contact, such as it's usually a specialist, doctor, sometimes charge nurse or physician's assistant. When I started calling providers, I introduced myself, where I was calling from, explained what I was updating, and that I was from the Department of Health, and ensured that that was the proper number to contact if there are any questions about disease surveillance or specific patients' medical records, and what preferences that they may have. If there was no specific contact person, I left that section blank. A lot of the time it would just, someone would answer and they'd be like, anyone available to speak? For that one, it's usually any available nurse or anyone available in the medical records department. And if the person I got in contact with told me, yeah, any doctor, I would list that as well. So I made sure to include that all in the notes section. Additionally, I asked if they had a fax or if the current fax was listed was updated and edited the sheet accordingly. A lot of places actually don't really have any preference for fax, so there's not that many fax numbers listed. They just prefer you call them, which is understandable. A lot of the time they are very busy. They don't have time to check. And then I asked if there were any additional preferences that they had. And I also noted if a specific number was really difficult to contact or if a number wasn't working. So I made sure to go down the list. And this is all explained in this flow sheet here. So the results. I think it was pretty successful. Out of the entire point of contact list, which has 133 contacts, I was able to get a hold of 90 of those. Of the total number of clinics, 56 were updated, which accounts for 42% of the 133. And of the total list, 77, which accounts for 57%, were not updated, either because the information in the column was still correct or I was unable to get a hold of the contact. And if I was unable to get a hold of the contact, I noted it in the notes just so it wouldn't affect further down the line, just in case they thought it was updated. On the right here, it lists all the providers that I could not get in contact with, which is a good amount. I tried to reach them multiple times, but for some reason, I was just not able to get a hold of them. So some successes that I'd like to include and discuss was that I was able to get a hold of about 67 providers of the providers listed. And that's pretty great. You know, that is more than half, I think, especially since it is sometimes really difficult to get a hold of them. I was still able to get a hold of them. And out of that, I was able to update 56 providers out of the entire 133, whether it was numbers, facts, specific people to call, I was able to update information. And that accounts for 62% of the total providers contacted of the 90 contacted, and 42% of the total provider point of contact list. So meaning 62% of the people I contacted, so 90, so 56 out of 90, I was able to contact and update information, and 56 out of 133 was where I was able to contact and update information. For 56 providers, there's now established point of contact that can discuss medical records or specific cases of infection control when needed. And the guide that I created that I showed in the previous slide is a great tool building block to assist in cooperation between the Department of Health and the stakeholders in the community, in addition to providing documentation on how to use a tracking tool, so they both work hand in hand. Some challenges and obstacles that I like to discuss. It was very difficult getting a hold of a live person a lot of the time. I would be sent to either automated messages or um, any kind of directory, and I had to work from there. For some large institutions or hospitals, again, I was directed towards an operator, so I kind of had to jump through a lot of hoops. A lot of the time, they didn't really know what I was talking about, so they would send me to a random department, and I would have to kind of hop around. And then for smaller organizations or direct lines, I would either get sent to an unnamed voicemail box, so I couldn't confirm if that was a specific person I was trying to get a hold of, or sometimes the number was no longer working. Um, yeah, specifically for one organization that seemed that they no longer existed. Um, Time constraint was a barrier I had to get past due to the amount of time I could spend attempting to contact every provider. Some of the providers I was not able to contact. I attempted to call them several times, and for some reason, I could not get a hold of them. I attempted to get contact with them different days, different times. I tried to avoid lunches, or if it was too early in the morning or too close to going home. So yeah, I was still unable to get a hold of that list. Another kind of obstacle was, since I'm an intern working remotely, I don't have a specific Department of Health email or extension to leave. So I wasn't able to leave a voicemail, or if anyone wanted to ask me additional questions on my end, I wasn't able to provide much except my supervisor's contact information. Yeah, the conclusion, I'd like to point out that the point of contact list is a sentinel approach to disease surveillance. Yeah, it was trying to find specific providers that we can get in contact with that can report data to us. Through the point of contact list, it's able to identify who the designated health professional is that must be contacted if there are any questions regarding a specific person or group based on diagnosis. And being able to use a guide in the future to keep a point of contact list will hopefully greatly benefit the harm reduction services branch in keeping tabs with local stakeholders and to keep collaboration among the infectious disease community. So yeah, just professionals in the harm reduction services branch are able to use that guide to update that list and continue to improve communication among other providers. Some public health relevance and implications. The tools offer data information for public health professionals in the harm reduction services branch, the Department of Health, to be able to inquire new sentinel disease surveillance for sexually transmitted disease cases. And both projects were a great way for Department of Health to show leadership and applied collaboration among local communities and clinics in Hawaii. And they're both able to assist in a quick and smooth route of communication, which will continuously support our leadership in the community. Some MPH competencies that I like to go over that I reached through my capstone. There are 4. So the first one, I was able to assess the public health implications of environmental conditions, political landscapes, population characteristics, and movement, and vulnerabilities and capacities unique to Hawaii and Pacific region. I was able to meet this competency by discussing the health implications of the geography and environment that is unique to Hawaii. The paper or the capstone discuss the specific geographic characteristics and challenges Hawaii can pose to disease surveillance. The capstone also included population characteristics such as the census of Hawaii and how important it is to collaborate with stakeholders who track the health of local communities, track homeless populations, and also military personnel and their families on the islands. These demographics were discussed and how they are unique to the state of Hawaii and other unique characteristics are important to track in regard to disease surveillance, including STD surveillance. The next MPH competency that I was able to use was propose strategies to identify stakeholders and build a coalition and partnership for influencing public health outcomes. So the capstone met this requirement by discussing how the Department of Health and the Harm Reduction Services branch was able to identify stakeholders and build coalitions by determining specific health professionals who can be a point of contact in regards to disease surveillance. The importance of establishing points of contact was discussed throughout the paper and was highlighted to be vital to the unique geography and demographic of the state. Next, I was able to apply leadership and/or management principles to address a relevant issue. I was able to do this by addressing the types of disease surveillance that is normally used in infection control and which specific methods were used throughout the projects discussed. Capstone includes discussions of where there needs to be improvement on the specific tool of disease surveillance. This offers a management principle of improvement and organization. And then the last one, I was able to integrate perspectives from other sectors and our professions to promote and advance population health. And I did this by discussing topics and information from a myriad of other sources that I included. The capstone included in the capstone included a lot of my own information and education on what I learned from specific projects that I worked on. So I was able to include that as well. These are all the references I used throughout my capstone. What we would take from this experience and how I will apply it to a career in public health or a career in the future. I learned a lot. I learned how important it is to be involved in the community as a Department of Health or as a public health organization. And I also learned how much structure and organization is so important in disease surveillance. Making sure that you have an updated data sheet and continuously updating it is very important. I learned how important it is to acknowledge and understand the diversity in a community. This will greatly benefit everybody's health, so we're able to collaborate with everybody. I learned patience is a big factor in public health. There is a lot we have to manage at once, and doing little things or having small tools can help in great ways. I'll be able to apply a lot of things in my future career because I'll be able to understand how things just don't happen overnight, and a lot of things happen because there are a lot of public health professionals working behind the scenes, and there's a lot of collaboration going on between every organization in the state and in the community. So I definitely will be able to apply that. Also, being able to use more data-driven tools will definitely be beneficial, since I worked a lot with the Excel sheet that I was working on throughout the class. I've gained a lot of respect for public health professionals and how much there has to be balanced. And a big thing that I would take is learning patience and having to trust in local communities and stakeholders when it comes to, improving the health of the public. Here's all my contact information if anyone has any questions. Here's my email. That's it. Thank you.